Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
So now we're going to learn a little bit more about Alzheimer's. And there's no better way to learn than from a doctor like Dr. Richard Singer, who is an MD, and he's a neurologist, and he represents the Sunrise Medical Group. Now, the Sunrise Medical Group has over 30 years of clinical trial experience. And you know, I want to go over that with Dr. Singer. I want to know exactly when it says you conducted more than 300 central nervous system disorders. What does that take to do that, Dr. Singer?
Well, first, let me make a slight correction here, because the research business is Infinity Clinical Research, which is independent from Sunrise Medical Group.
Okay.
But Sunrise is my neurological practice. And having said that, we've been doing studies for, as I said, many years. And we've done studies in Alzheimer's disease, in what's called mild cognitive impairment, mild memory loss, Parkinson's disease, multiple sclerosis, neuropathic pain, including shingles pain, including HIV pain, including diabetic neuropathy. We've done numerous migraine studies, both for acute migraine and for preventative therapy. We've done fibromyalgia studies. So there's been just a host of clinical trials that we've participated in, and a lot of the studies that we've done have ultimately turned into marketable medications, which your listeners are taking at this very time.
This must be very exciting to you to have gotten into this. You know, years ago, when someone becomes a neurologist, they didn't have the all the, I would say, apparatus and all the ways in which to really get into what the causes are and what the possible treatments are. Isn't that true?
Well, clearly during the course of my career, we've gone from minimal testing. I mean, CT scanning was just at its beginning when I started training. And now, of course, MRI has been around since 1985 around, and that's changed the way we diagnose neurological diseases. There's now PET scanning, which is another technology, especially useful in diagnosing Parkinson's disease, and Alzheimer's disease. But unfortunately, it's not yet fully approved by Medicare. So we do this PET scanning in Alzheimer's trials, and the clinical trials that we're doing, and it's available that way as well. But also in other diseases that we've been looking at over the years have been incredible advances. It used to be said in neurology you could only manage people, you really couldn't really help anybody, but that's not true at all, because in migraine there have been tremendous changes. In multiple sclerosis, the new drugs have truly altered the outcomes of so many patients. We're trying very hard to find better medications for Alzheimer's disease, and that's been difficult, but there are a number of trials that we're doing now, and we're hoping that these will prove to have positive outcomes.
This is so important. I remember, and as a gerontologist, I remember when people said, oh, well, my mom has Alzheimer's disease, and they didn't know that. They just said it. And yet, at that time, there really were no ways in which to pretty much assess that. But now, of course, with the scanning and all that you were talking about, there really is a way to know that it's Alzheimer's. Is that true?
Well, to date, there's no commercial what's called biomarker that diagnoses Alzheimer's disease. In other words, you just don't go to the doctor and they do a blood test, send it to the lab, and it comes back Alzheimer's. It's really a clinical diagnosis, and then we use other methods of trying to support the diagnosis. Now that PET scanning is available, we can actually see what's called the amyloid load. Amyloid is a protein which accumulates in a greater degree, actually too much, in certain nerve cells in the neurons, and it's felt to interfere with the transmission of certain brain signals. And this can be seen, but to date, we know that there are certain medications that we've been testing that reduce the amount of these proteins in the brain, but it has not yet translated into a positive outcome measure in terms of the patient. And this is why there's all this research going on to look to see if there is a way, not just to rid the brain of the abnormal proteins that are accumulating, but to make it such that by doing so, the patient's memory improves.
That's just excellent. And you, of course, now the whole thing is Alzheimer's everywhere, and we're just so hopeful that people like you in the clinical trials and all over the world really make a difference. And I know I heard something about, and I'm having a little hard time figuring out how to pronounce it, idalopyridine.
Right.
Is that how you
That's
say
a pretty good start.
Okay.
Right. And that's a medication we're looking at. It's actually what's called a selective serotonin receptor antagonist, which means it attacks a certain type of neurochemical receptor in the brain in the hopes that it's going to improve a cognitive performance when it's given in conjunction with a commonly prescribed medication for Alzheimer's called donepezil. Donepezil is a generic form of Aricept. So in this particular study we're doing, patients are already taking a prescribed, approved FDA medication called donepezil, and this is added on to it in the hopes that together these drugs will have a positive effect in improving the patient's short-term memory.
Well, we applaud you, and we wish you so much good fortune with this, because not only is it going to make a difference in people who have Alzheimer's already, but what can we do with the baby boomers and all the Gen X's and all the other people coming up? Because that seems like that's the biggest worry they're having.
Well, unfortunately, the incidence of Alzheimer's disease is increasing greatly, and it's felt by 2050 there'll probably be 13 million people in this country alone. Right now, it affects between 4 and 8% of the population above 65 years of age, and depending on the statistics that one reads, between 20 and 50% of those 85 and above. So it's pretty, prevalent in the population. Of course, so many people come to their physician or to a neurologist with mild memory problems. They can't forget their keys. They do forget their keys. They lose their glasses, this type of thing, and they're afraid that they might have Alzheimer's disease. So as you said, there are ways now of assessing patients clinically and with certain tests to try to come up with a more specific diagnosis. And then, of course, there are medications that are approved. The medications that are approved for Alzheimer's disease hopefully slow down the progression of the disease. They do not, unfortunately, reverse the course of the disease. And that's why there's so much active research going on to try to find a medication that will ultimately reverse the progression of the disease.
Let me tell you why it's so important you're listening to Dr. Singer. Dr. Richard Singer is part of the largest neurological practice in South Florida, and he received his medical degree from State University School of Medicine at Buffalo, followed by his residency at Albert Einstein College of Medicine in Neurology. And one thing that I know neurologists who are working in clinical trials want, they need patients. They want people to come and be a part of it. And I've always said, isn't it a wonderful thing to think that if they find something that works, that you were a part of it? So the way to participate in the Alzheimer's clinical trial is to go to floridaalzheimers.com, or you can call 1-844-523-9478. Is that correct, Dr. Singer?
Yes. And
okay.
Or to the office directly, to the Infinity Clinical Research, which is 954-475-8171.
Oh, good. So I just wrote that down. So it's 954-475-8171. And
yes.
This is wonderful, why I love to have people who are involved in clinical trials. I was involved in some clinical trials, and it was very exciting. Of course, people don't know if they're taking the real substance or if they're just, just taking something else. But it doesn't matter, because that's how you find out. So have you been involved in a lot of clinical trials? I mean, personally? I mean, do you love them? Do you enjoy this?
Yes, like I said, I've done over 300 studies over the last 25 years.
You better like them, right?
But you mentioned something interesting, because patients are always concerned about whether they're going to get placebo. All medications that come to market, the FDA requires that they be studied in double-blinded, placebo-controlled fashion, which means neither the investigator, the physician, nor the patient, nor their family know where they're getting active drug or inactive drug. In these particular studies that we're doing, patients are not denied therapy because they're going to continue on the medication that they're on in most cases. And then, yes, they may be on a placebo, they may be on active drug, but there are clear advantages in terms of participating in a clinical trial. And of course, it's completely voluntary. There's no cost to them. It's all paid for by the pharmaceutical sponsor. They can withdraw at any time if they so desire. And we're testing something which is not available anywhere else, commercially. Patients are closely followed, so they're getting medical care at no cost to them. And hopefully this may reverse the course of the disease. They'll also be able to, depending on the study, get a PET scan, which is not commercially available, which would be available through the trial. And there's a tremendous amount of TLC involved because the staff are very familiar with Alzheimer's patients and know how to basically take care of these patients and their families. And there's a great need for this. In a busy neurology practice, the neurologist and the staff may not have the time to devote to the families in this way. But in the clinical trial, because there's so much testing and neuropsychological evaluations that are going on, there's a whole group, there's a whole team that's working with the patients and their families. And it's important to add that a caregiver is required to participate in these trials because that's part of the outcome measures to determine whether the drug is effective or not, because we need the caregiver and the caregiver's impression of what's going on with the patient.
Oh, that's excellent. I'm glad you mentioned that. So for people who are listening, why don't you make that phone call? Just you can call locally down here in Broward County, 954-475-8171. Remember, this is Pencil Talk Radio. Get your pencils out and write these numbers down. And where you're going to be taking part, hopefully, in the Alzheimer's clinical trial. And you do have to have a person that comes with you with a caregiver. That was an excellent thing. I hadn't thought about that. Now, would you tell us the procedure? So someone may not be eligible to participate. How is that done?
Well, each study has its own what are called inclusion and exclusion criteria, meaning patients have to meet certain criteria to participate. That has to do with their clinical examination. It has to do with other medications they're on, their past medical history, and there may be certain medications they're on which will exclude them from the study. We don't know until we actually screen them to know. And they have to have a certain score in what's called the mini mental status examination. But we're doing studies for early onset Alzheimer's, for moderate disease, and for more advanced disease. So it's quite possible they would fall into one of those categories.
Yes, I see. And so that's why you need the staff, of course, to segregate it, see what has to happen. Are you having, do you have a lot of people who call to get into the clinical trials? I mean, how do you have to convince them to do this?
Well, sometimes, you don't have to convince patients at all because they realize, and the families realize, that there is no medication available that's going to alter the course of the disease, and they'd like to try something new. Again, patients to participate, they or their family member, depending on the severity of the patient's disease, have to sign informed consent. This is required by the Federal Drug Administration, and the informed consent outlines the study in detail, including potential risks, and patients have to be fully aware, and the families have to be cognizant of these issues. As stated, it's completely voluntary. There's no cost to the patient. Depending on the study, they may get reimbursed for travel expenses, and that's usually the case. But there's an important issue here, and that is that patients, when they're participating in a study, they're getting a lot of care from not just the physician involved, but from the supporting staff who are very experienced in taking care of Alzheimer's patients.
All right. So are you looking for people who have early signs of Alzheimer's or people who are moderate or even more severe? Does it matter?
Well, in the particular study that we're talking about today, this is a study looking for medication to help improve patients with mild to moderate Alzheimer's disease. And but as stated, we're doing other studies for more mild disease and for more advanced disease as well. So if they call, we can screen partially on the telephone, but most patients would have to come in to be evaluated to see which trial they might benefit from.
Yeah, that's excellent. And so I hope that our listeners will really do this. I know how critical it is for you and for your families. And, of course, many of you don't really even know that you have Alzheimer's. I mean, you don't think that. But your family member will recognize that there's something wrong. And so please listen when they say to you, Mom or Dad, I'd like you to call, I'm going to call this number, and I'd like to go down there and help you get tested. And I know that my mother did have Alzheimer's. At the very beginning, we didn't know, but it was it was the Lewy body type.
Well, Lewy body dementia is a different entity.
Oh.
Very often they have patients present with hallucinations as
yes.
a presenting sign, and they may actually look like they have Parkinson's disease. So there's a relationship. But the study we're doing now that we're talking about today, patients with Lewy body disease would not be eligible for that study. But at times we actually do studies just specifically for Lewy body disease.
That's great that I didn't really know that you were down there. I am so happy to hear about you and your organization. It sounds like you should be very busy with what you've chosen because it isn't just Alzheimer's, although that's the major point, and that's why we are very happy to be able to get people to think about it. I was at an Alzheimer's conference recently, and a young woman, she's 49, and she now knows that she has early stage Alzheimer's, and she's going through some testing, but she's also wants to become a spokesperson because she always was a great communicator. I don't know if you know the name Dottie Carson, but she's someone that I'm sure you would love to have someone who can really talk about it and work with you.
That would be interesting.
Yeah, it would be, wouldn't it? Because I don't know, who your patients are or how that works. But anyway, let's get back to being a neurologist. What else are you doing as a neurologist? Let's say a person. Why would someone come to you to begin with? Forget the Alzheimer's right now.
Well, neurologists take care of patients with diseases of the central nervous system. So headaches is probably the most common thing that we see. I've been doing research in migraine, for example, for 25 years as well, and have some very interesting studies going on right now for preventative therapy for migraine. Patients' diabetic neuropathy is another common ailment that we see in neurology. So we evaluate these patients to determine how severe their disease is and whether or not they would benefit from medications. We're actually doing diabetic neuropathy studies as well. Parkinson's disease, we see lots of patients with movement disorders, different types of tremors, difficulty walking, difficulty with balance, goes on and on. Patients with multiple sclerosis, with other neuromuscular diseases. So it's pretty varied, because neurology really consists of evaluating the brain, the spinal cord, what's called peripheral nerves, and muscle. So there are primary diseases of nerves, primary diseases of muscle, primary diseases of the spinal cord, and, of course, of the brain.
And the brain has taken such prominence now. I mean, I would say 30 years ago, there were other parts of the body, but now everything is the brain.
Well, there's been a big movement in terms of brain attack for stroke patients. I didn't mention stroke because that stroke is really seen mostly in hospital setting. But and we used to do a lot of stroke studies as well. And there's been a lot of advances in stroke, and patients are always encouraged to get to the hospital as soon as possible because there are so-called clot-busting drugs that are given on an emergency basis, which have shown to have a beneficial effect in improving outcome measures in stroke.
Well, I have you on, and you're talking about that. I was very curious. I have heard that so much that hopefully the hospital nearest you has that. How can that make the difference?
Well, a stroke, there are two types of strokes, basically. There's infarctions, which means lack of blood flow, or hemorrhages, which means basically too much blood flow. So one has to determine what type of stroke it is, which is why if one gets to the hospital urgently, quickly, and have a CT scan, we can determine whether or not it's been a hemorrhagic stroke or a dry stroke, so to speak, without blood. And in those cases, then there's a drug called TPA, which is a clot-busting drug, which is given within the first 3 hours usually, to try to actually dissolve the blood clot that's causing the lack of blood flow to the particular part of the brain. Now there's even more advanced technologies in which, in certain instances, a catheter can be put into the blood vessels, into the artery, all the way up into the brain and remove the blood clot. It's pretty extraordinary what's going on.
That's very exciting. Do you do something like that?
I don't particularly, no, personally I don't do that. And basically now I limit my practice to the office out of choice. But, it's always very important that someone who has signs of a stroke, which may be one-sided numbness or tingling associated with some speech difficulties or weakness of an arm or leg, should be evaluated immediately.
I'm just enjoying this so much because I get to ask you all the questions I've been wondering about. When someone has what they call palsy, let's say if someone is older and all of a sudden the one hand starts to, have tremors, is that something that can be helped, or is that just with age?
Well, if it's a one-handed tremor, it depends on what's causing it. So it's hard to say. There are certain types of tremors which run in families, which are usually present when the patient is doing something, meaning eating or lifting something up. There are other tremors, which is like a one-sided resting tremor, may suggest that this is the onset of Parkinson's disease. So it's very variable. And if it is, there are things that can be done. Absolutely.
You must have a lot of fun with what you do, because you can really help people, and I know that's important. And you've been doing this a long time. Do you have a particular patient that you feel has been something very successful for you that you'd like to share? I mean, usually doctors, I interview so many, and there's always a couple of things that I had this patient and this happened and we did that. Is there something that comes to mind? I hate to spring this on you.
Well, probably the most common thing that I see in the office are headache patients, And when you see somebody who's been having chronic headaches for many, many years, they've been on every known medication, and they're just getting worse instead of getting better, when you can do something and reverse their course, because I take headache very seriously, that it's really a neurobiological disease. It's not just, quote, another headache. So, yes, I've had patients who, for example, we do Botox for chronic migraine, which has an approved FDA indication. And if you choose the right patient, patients can do very well. So I've had a patient I just saw this morning, actually, who came back after her first series of Botox injections for chronic migraine and is probably 90% better. So for the first time in a long time, she's passed on through an entire month with no headaches, essentially, as compared to someone who was suffering on a daily basis. So that's pretty dramatic and pretty remarkable.
It is. Where do you put the needle in for a migraine?
There are 31 injection sites, and it's from between the eyes to the forehead to the temples to the back of the head and to the neck muscles.
I'm very impressed. I know I've heard so much now about Botox and even helping with incontinence and other kinds of places to get that muscle, tight. Well, that's good, because there are friends that have migraines, so I should really send them to you. Sounds like.
We see a lot of patients with migraine, that's for sure.
Sometimes they say, oh, well, it's just stress. But you're saying to us it's got to be more than stress. I mean, do people just come into you and you wind up telling them you're just got to have a better life because it's too much stress?
No, usually there's more to stress. There's more to migraine and more to headache than just stress, in my experience.
All right, and let's ask about all this. Let's go back to Alzheimer's, because that's really where we started. This is running in families. Is that one of the most important questions that you ask? Did anyone?
Well, of course, we ask that question, but there are certain families in which the incidence of Alzheimer's disease is relatively high compared to others. Is there a direct genetic link? Well, there are certain codes that we see in patients' genetic history which may suggest that. And in certain Alzheimer's studies, we have to determine whether they are so-called positive or negative, whether they participate or not. But there's not a direct linkage. We wouldn't send somebody for a blood test to see if they're going to get Alzheimer's disease, at least not now. We want to wait until there's something you can do for these patients definitively.
I went to a conference for Parkinson's, and there are some there's testings that are going on to be able to see if they have this particular cell. It's in their cell.
Yes. Well, there's different types of tests that are being done. There's even this type of scan that's done to help differentiate Parkinson's disease from certain types of what's called essential tremors. And there's more and more different types of biomarkers being developed, but there's no specific blood test right now that you would just send routinely to the lab, which is going to diagnose Parkinson's disease.
And would that be something that your organization would be testing? I mean, you're doing clinical trials, so are you...
We're doing clinical trials and different medications for Parkinson's disease. We're not presently doing any so-called biomarker trial, but we have, and they come periodically. We are testing those things.
And this all starts out with the pharmaceutical company, doesn't it? I mean, when you think about when someone says, well, this drug costs so much to develop, and then you're the clinical end of it, aren't you? So that to see if it really can go to market.
Right. Well, we're doing what we call phase 2 and phase 3 trials. These drugs have all gone through phase 1 testing on normal volunteers to determine safety issues. And then they go through phase 2 testing for safety and phase 3 testing for determination of dosage and efficacy to see if the drugs really work. And then they go into phase 4 testing ultimately, which is post-marketing. It's just after they come to market. So the programs, this goes on for years before a new drug actually comes to market. And the research and development costs involved with this are astronomical. I'm not here to defend pharmaceutical companies, but they do charge, a lot of money for these new medications. It's always a challenge in clinical practice if there is a new exciting drug to try to get it authorized by the patient's insurance, because very often the insurance companies don't want to pay for these new expensive drugs. They want to pay for generic drugs only.
Right. Well, Dr. Singer,
challenge practicing.
Thank you. We're just running out of time, but I can't thank you enough. We learned so much in this short time. Imagine less than 30 minutes, everyone listening saying, oh my goodness, all these things. But we hope that they will call you, 954-475-8171. You've been listening to Dr. Richard P. Singer out of the Sunrise Medical Group, and I'm Anita Finley, and thanks for listening.